So now that leads us on to the. Initially, you started with a vaccae bacterial preparation and went on to an OBNC preparation. These greatly stimulate the innate immune system, which have really significant anti-cancer properties, for sure in some cancers, and probably to varying degrees in all cancers. Can you fill out the story of this a little bit for us, Gus? So what started with the vaccae, and how did that go on to the OBNC, and what are these bacteria and how are they working?
Right. Well, Mycobacterium vaccae was basically discovered and developed by Graham Rook, John Stanford, and John Grange. Sadly, the last two are departed, but I worked with them and learned an awful lot. They were trying to develop something better than BCG.
Yeah, which is the tuberculosis.
Yeah, for tuberculosis. Yeah. And they found a bit by accident, and serendipity and accident, that BCG worked much better in areas where there was Mycobacterium vaccae. So they looked at vaccae to see if you could stimulate the immune system.
And this basically comes from cows, presumably?
It comes from cow dung, so
right.
Cynics have accurately called it bullshit.
Yep, fair enough.
And so, but that is, goes all the way back to the so-called interpretation of the dirt theory.
Yes.
You need this dirt to stimulate your immune system when you're young. Yes. And as you get older and more sophisticated, you get less stimulation with this. So it was a way of boosting what was already there, to give it a boost of the innate immune response. And the big thing is, I've been involved in cancer vaccines for 25 years, and what we discovered is that cancer vaccines, the majority, are useless. I don't really like to admit that, but because that's what I was doing.
But the cancer vaccines that you're talking about there are fairly specific, aren't they?
Exactly.
You're giving a specific antigen, not boosting the immune system as a whole.
Totally 100% correct, because everybody in all the companies went in this. They went for the cancer antigen, the target, MARG, MART, NYESO, on and on. And we found when we targeted these that the tumour thought, I'm not having this, and basically, like someone being shot at, ducks, puts a shield over their head, mutates and carries on.
A couple of mutations and you're away.
So this seminal moment is when I was working with Graham Rook and John Stanford, when they showed that the patients, when they were using for a TB vaccine, that they switched on the suppressed cell-mediated responment.
Switched on what, sorry?
Cell-mediated response.
Cell-mediated response,
yes.
yeah.
So there's a chap called Rossman who basically showed that the immune system is like a big seesaw, and it's a Th1, Th2 he called it. The Th1's a cell-mediated response, which produces things like IL-2, gamma interferon, and that boosts the T cells.
Yeah. These are cytokines that the immune cells release.
Yes.
That boost the cells that actually kill the cancer cells, or kill the virally infected cells, or kill the bacterium.
Yeah. But on the other side of the seesaw are the Th2, and these are the cytokines that produce antibodies and inflammation. And what they found, and then I found the same thing in cancer, was that if you've got HIV, TB or cancer, the cell-mediated response is completely suppressed. It's like someone standing on the brake, and the equilibrium dynamic effect of that is to compensate by boosting antibodies and inflammation. Now what we found was when we gave these patients vaccae, the equilibrium improved. It was really quite fantastic. Yeah. And I said, this is something that I really want to use in cancer. Yeah. And so I did. Sorry, I'm afraid this is... I just turned it off. I should have thought of that. But
you always forget something.
Yeah. So I said, I really want to use this in cancer because we've just done a load of really basic work into the immune system, and all our cancer patients are just like the TB patients. The cell-mediated system switched off, and the antibody inflammatory response is overcompensates. And that gives a milieu where these things thrive. Whether it be
it's amazing, isn't it? So cancer can basically turn off the body's natural immune response to itself.
Yes.
Amazing.
Yeah. Yeah. And so I said, can I have this? And can we give it to patients? And these are the days when you didn't have to go through all these regulatory things. I went to the chairman of the ethics. I said, I want to do this. Looked at it. Said, okay. Went to the next ethics committee, signed it off.
That's when you were allowed to be a doctor.
This is when we're allowed to be a doctor and do proper clinical research that we can't do now.
So this is the Mycobacterium vaccae we're talking about now. This book.
We had amazing responses in some patients. As I've said, these patients were the only patients that had good vitamin D levels. So the two of them, and then we looked at what it did. We found that it boosted these intermediate T cells, the innate T cells. So there were natural killers, gamma delta T cells. And when you read about these things are very, very good at killing tumours and unknown infections before you develop adaptive immunity.
So these natural killer cells, they're big lymphocytes, aren't they?
Yeah.
They would just come up to a cancer cell, basically deposit cytotoxic chemicals on it and just kill the cell.
Yeah,
simple as that.
And that's why they got called natural killers.
Yeah, great term. They're the killers.
They're the first line of defence. And then thereafter, with all the cytokines and imprinting, etc., you get the adaptive immune response, which interestingly is not nearly as good. This was the insight we had. So until you boost that innate immune response, everything else is not going to work as well. Yeah. Now, going back to all this, we did so much scientific work at how Mycobacterium boosts the immune system, and it's all the innate, it's not the other thing. And we found then that, I went to these meetings in the States when they had these checkpoint inhibitors, these drugs which are causing tremendous responses in melanoma, lung, etc., these checkpoint inhibitors. But individually, they never go more than 40%. So I went round this big meeting and I found different groups that said these drugs only work if you've got activated natural killer cells. These drugs only work if you've got activated myeloid-derived dendritic cells.
That's a particular type of white cell that will combat cancer cells.
I said Mycobacterium vaccae does both. This explains. So we completed a study and we published it showing if you prime with vaccae, then the response in melanoma patients nearly doubles.
And the downsides to priming with vaccae?
None.
Well, this is a complete no-brainer, isn't it?
Well, this is a complete no-brainer, which is why I'm so devastated that the company that was doing all this has run out of money and gone into administration. Because when I talk about vaccae, we went to Obiensi, which is like a twin cousin, but it's actually much easier to manufacture.
So it's still a mycobacterium.
Still a heat kill mycobacterium. This is the thing.
It's a particular process. It's rather analogous to making a particular type of beer. You've got a particular brewery that's got particular techniques, and you get that taste you're looking for.
Yeah, but that is, and so the whole production of this is process, because if you don't heat kill it properly and you don't buffer it and all these things, it won't be active.
Yeah. It's a sophisticated manufacturing
from a company's point of view, this is a process that they're only not the end product exists around the air, but getting it to a thing where you inject it and you get this great immune response, that's what the company were doing, and they were taking into pancreatic cancer. The whole thing's, to me, has been a tragedy, because they got the manufacturing sorted out, the FDA had approved all the studies, the trial was up running, just recruiting its first patients.
The trial's actually in process now.
Yeah, so all that development, and this unfortunately is why the company's run out of money, because all this should have taken 6 months or so, but it ended up taking 18 months with all these delays and things with
all the red tape, all the hoops to jump through,
and regulations. And
Yeah.
so everything's set up. So I think it'd be an absolute disaster. So I make no bones about it. It's gone into administration in Modulin, and we are desperate for someone to come along and rescue it and finish the study and get it approved.
Is there any doubt? Is there any realistic? I mean, the reason you do the study, Gus, of course, is to find out whether it works or not. But all the prognostic indicators in your mind, what's your feeling? Are you pretty confident this is going to be an effective anti-cancer treatment?
I'd like to turn your words around about it, because it's very insightful. The reason you want to do this is to prove it. I know it works. I have used it for 25 years.
Right, there's no doubt about it.
Every single study we have used it in has been positive. And there was a recent a German European group who used it prior to focused radiotherapy CyberKnife. And they have published that this enhances the response and gives them a better response to radiotherapy. Yeah. So there's never been a negative issue here. There's never been a serious adverse event of greater 3 than 4, and which in the Pfizer study for the COVID vaccine there were 42,000. I mean, I'm not joking. It's never been one. So we shouldn't have
42,000 versus 0. Yeah, I like the sound of that.
Yeah. So we should not have to be doing this study.
No.
This is this is the regulators absolutely. It's literally like they want anything useful not to succeed or make it so expensive that eventually, say, Big Pharma gets involved. Because the reason I became so anti the EU was because the European Union Clinical Trial Directive I saw was basically a vehicle for Big Pharma to stop or control all clinical academic trials, all small pharmaceutical trials. Unless they got involved, they were going to die, be dead in the water. And that's exactly what it looks like. So I believe very much that this thing is so obviously works, and all my colleagues have used it. I mean, they love it. They want their patients to be on it. But
I want it because you stop getting colds and flu as well.
Yeah, well, actually, also because of your age, that your innate immune system, in spite of the vitamin D, is not as good as it should be.
It certainly isn't.
Whereas with the Mycobacterium boost, it would be back to when you were 50.
If you had it, I would drive down there now and roll my sleeve up and get you to inject it in if it was available. Yeah. It's just not available. So.
Well, I actually believe that the first thing they should do is allow it for cancer studies just to monitor. It's so easy. We did it in a phase 2 study that everybody who was going to have pembrolizumab or nivolumab for melanoma, that if they elected and approved informed consent. Do you remember that? It was totally removed during the COVID vaccine days.
I do. I was injected without informed consent, and I'm livid.
They say, well, I like this. It's got the potential to increase my response from 40% to something higher without any significant side effects. Yes, I have it. Well, that's what the trial showed. And it's so black and white that I believe that any responsible regulator whose goal is to improve the health of the population without exposing them to any serious adverse problems, I believe that they should have released that under a phase 4. You know, we have phase 1 is what is the dose. The irony is that with VAKI and OBNC, it was a bell-shaped curve. So when they did the studies increasing the dose, they found that when you got to a certain amount, the effect diminished. So you reduce the dose, and it really is a case of less is more.
Yeah, you just wanted at the top of that bell-shaped curve, and then
so we know exactly the dose.
And you know that, so you would know how much to put into the syringe to inject into my arm.
To everything. And you know, I've mentioned we've done a randomised study in pancreatic cancer. We've done several in melanoma. We've done it with all sorts of combinations. And I suddenly look back that these weren't trials, but I were able to use it off-label. fantastic stability in stage 4 prostate cancer. We had complete stability in mesothelioma, which is still one of the most difficult, ovarian and colorectal and lung. So this is a generic thing. This is not a one type of tumour or one.
You've described completely different histologies of cancer there, haven't you?
It is. It is across the board, and it makes everything else basically work better, whether it be immunotherapy, chemotherapy, or surgery and radiotherapy. And my surgical colleagues loved me to start the patients on this before they did surgery, because they recovered so much quicker and they didn't metastasize afterwards. And so, which shows that, and then we'd actually already done studies which showed that the bigger the scar, the longer the operation under anaesthetic, the worse the immune suppression was, and the longer it took to recover. So the surgeon I worked with basically said that obvious thing to do is give it before I operate to boost the immune response, and then I'll do less damage. This particular surgeon, who's a really top pancreatic surgeon, Savinda Mudan, who worked at George's and elsewhere, he basically was the first to be absolutely sure that it was really an issue doing the big Whipple's operations and pancreas, because he could do technically superb, but so many.
That's a sophisticated procedure to take out the cancer in the head of the pancreas.
Fantastic. But it takes hours. It had a big scar in those days. You can do it laparoscopy now, and the immune suppression lasts several weeks. And at that time, several weeks, you totally remove the tumour, but suddenly it appears, its secondaries all over the liver. So from a surgeon's point of view, done a technically beautiful operation, but it's a waste of time. Because so the idea of boosting the immune response so you don't get this suppression, so you don't get post-operative secondaries, is a concept that the surgeons embraced long before the medical oncologists. I mean, Donald Morton, who I worked with in the States, who has developed his BCG and tumour cell-based vaccines, he was actually convinced that he could cure people with surgery, providing he could address the immune deficiency. And we're talking like 70s, 80s. He had this insight, along with many others. But the medical oncologists, with their wedded to the chemotherapy, didn't really see much room for immune therapy until the last decade, basically.
So we've got a treatment that's probably effective against preventing and treating a wide range of cancers, a wide range of infections, but our regulators won't let me have it.
Yes.
This is kind of hard to come to terms with. But given that a modulin, which we might call a small pharmaceutical company, is going into administration, and this has got the potential to prevent and treat a wide variety of cancers, can we rest assured that Big Pharma will be so moved with compassion for all the people with cancer that it'll immediately start manufacturing it itself?
No.
Oh.
No, I'm afraid.
Well, that's a pity.
I am afraid not. And I mean, this substance is so good, I believe it would improve the health of the nation in more ways than one, because of the ability to boost the innate immune system means not that the vaccines are not going to be needed. Now, Big Pharma is wedded to jab. The more vaccines, the merrier. They see it as super profitable. And one of the people I spoke to, and I can't mention names here, obviously, who was very interested in it personally, who worked for a Big Pharma, he said, I think this stuff is absolutely fantastic. I will push it. And then he was incredibly honest. He said, there's an issue for Big Pharma, because it means if we use this, that the costing and everything is limited. It's not an antibody, so we can't sell it for... Some antibodies are sold for £100,000 a course per year per patient. No society can afford that.
No.
With this, it could be super successful as just a few hundred, let alone 100,000 per year. I mean, it really
And work against a much wider range of cancers and infections.
Great. And he actually said to me, he said the problem is that the people who control these companies now are accountants, and they could see this would prevent their ability to use 2 or 3 monoclonals at 100 grand. And eat into the profits because they're only in profit. Now this guy was in the company. He told me that. I mean, it made me think of someone who invented steam-driven engines and bought up by big oil companies and then completely locked away in the basement. It's that type of approach. They don't want anything that might reduce their profits.
The regulators in our country, in the UK, could authorise this. And for say they authorised it for treating melanoma or pancreatic cancer, which you're giving clear evidence of efficacy for.
Yes.
If they licensed it for those things, then that could allow doctors to prescribe it compassionately.
Yes.
For other things. Why don't they do that then?
Well, I don't know why they won't do that, but they can if they wanted to.
It's inexplicable. It's inexplicable.
I was talking about the stages of phase 1, phase 2. So we've done the phase 1. Phase 2 is does it work? Every single phase 2 study we've done, it clearly is of benefit. Phase 3 is the big randomised study which they want before they register and prove it. But the problem is those large studies cost 20 to 30 million because of the way they did the regulations. Yeah. But there is a thing called phase 4, a phase 4 study. And that means that you license it, but you haven't given it full registration, but people are able to sell it, use it, prescribe it, but you have to monitor it like it was on a study.
Yeah, and you collect longitudinal data in the real world as you go along.
And it's heavily monitored, and if that's fine, then it's approved. Now, I was involved very much with the thalidomide analogues and Celgene, who actually, I've no doubt, would actually have taken this up had they not been bought out by Bristol Myers Squibb. And I fought hard for the analogues, and we screened all these different analogues, and we came up with a drug that's now called lenalidomide. It's one of the most successful drugs in the world for myeloma and lymphoma.
Yeah.
It ticked every box. And I was amazed. They got that, Celgene got that into the market very quickly by using a phase 4 in France. So they were able to sell it, people use it. They said, my God, this stuff works. Everybody did it. In the meantime, they had a phase 3 somewhere else. So they got it. And, that drug is still selling over $10 billion a year. And it was licensed in about 2007. It's just incredible. But they were able to use that then to get it rapidly through, because everybody said that they got the new drug through to approval unprecedentedly quickly at that time. So that's the sort of thing I think that the regulators who said we've gone from regulators to enablers, but that looks like only for COVID vaccines. But they actually ought to remember they said that. June Rain said that. So
enablers of who would come to my mind.
Yes. So they should enable things that, and at the time when Cameron was Prime Minister, that was quite a way back, he actually, I believe for personal things, said that there should be a fast track for drugs that are active in cancer, that are active, non-toxic and cheap. Well,
active, non-toxic and cheap. That describes your bacterial preparation precisely.
And I spoke to someone in the MHRA at the time, said there were 45 applications under this scheme, and ours was the only one that ticked all the boxes. But still, in spite of that, in spite of the applications, no, they wanted another big study that nobody could afford. And this is what drives me mad. There's so many drugs like this out there that would benefit the health of the nation, are non-toxic, cheap, and work at the absolutely root cause of why we get ill, i.e. our collapsing immune response. I mean, the immune response sort of collapses after about 50, and it's amazing we do reasonably well as it collapses, but as it falls down the slope, the incidence of cancer rises exactly like butterfly wings. So you would have thought that if we're going on about the health of the nation, somebody would have thought that this is important. And there are just so many immunologists that would completely concur with that. And we're both friends of Robert Clancy. I mean, he would completely go along with this.
Completely.
So to have a simple agent like this is just a disaster that we can't get it to market. But I believe that one of the reasons I'm here today is that Imodulan ran out of money, but at the same time showed this substance was very active, totally non-toxic, and if it was approved, it could be available widely, cheaply. It would be a fraction of the price of any of the other drugs.
We've got a cheap, safe, effective anti-cancer preparation. This sounds like the Holy Grail.
Yeah, well, the big thing I was saying before is because with vitamin D in this, you correct the suppressed immune response.
Which caused the cancer in the first place.
Yeah, and then everything else works better.
Yeah.
So the chemo works better, the radiotherapy works better, surgery is more effective and less likely to be followed up by metastatic spread. So it is so obvious to do, but it is incredible that big pharma have looked at this, and the thing that has come across. I mentioned the first guy who says, "Well, it might interfere with our profits." I got it very high up to another big pharma, where the UK group were very high backing, but most big pharma now, the decisions are made in America because they're really all American. It's the Americans who run it, and basically it was dismissed as steam-driven, very old tech. We're interested in high-tech medicine. Well, sometimes steam-driven old tech works. Don't overlook it because that's what it does. And I've worked with many high-tech, and when I get really annoyed about the COVID vaccine story, the high tech goes right up there. I've worked on with people on CAR T cells, that meant to be the state of the art for liquid oncology. I have been on the scientific board of companies that specialise in messenger RNA vaccines, what have you. None of them are as good as this essential thing, and that is the thing, and they cannot cope with that.
And they're all specific, as opposed to this would work for everything.
Exactly.
Yeah. I mean, how do you? It's a pretty stupid question, really, but basically, you've dedicated your life to medicine, virology, and oncology, and you've basically found, without being too melodramatic, a cure for cancer that's now being buried and suppressed.
Well, I wouldn't say.
How do you cope with the frustration?
The frustration. I would never say it's a cure.
No, I overstate.
It enables cancer to be managed much more successfully. That's what it. And without it, this is the reason why the response rates to a lot of the cancers are 40%, 50. They regard that as marvellous. They're not 80, 90. This is, and I meet so many patients because they say, "Can you help me? We're interested in what you talk about," and they've had ovarian, breast, lung, bowel. They've had horrendous chemotherapy, and it's been
these patients are so ill. It can be barbarous, brutal.
They said, "No, we're not having any more. We just don't want any more."
I've seen that so many times. People that say, "No, I'd rather die than go through that again."
Yeah. So if you actually correct the innate immune response, and there's another agent we found boosts it very much. I think I mentioned it before as a low dose naltrexone because it damps down the inflammation. And I've given lots of patients the two. The result of that is you can give this really tough chemotherapy at half the dose and it's still as good. Well, all the toxicity is in the top 50 to 100% of the dose.
So it becomes way more tolerable if you give the low dose naltrexone.
And I've pleaded and asked patients, said, "Look, listen to me, go on this, and have that chemo at half the dose. And often I have other oncologists involved, and I have to tell them, that they're so programmed. You have to have the full dose. Well, you only have to have the full dose in tumours that you 100% eliminate. So that's like leukemia and testis. Every other solid tumour, it's not that it's not that linear. And basically, you can control the disease with low-dose chemotherapy, providing the immune response is good, and you keep it going for a long time. And this is one of the reasons we know it is controlled, because people have some big perturbation of the immune system, and that's how I noted the COVID vaccine boosters were causing this, and then it comes back. But
so that could be major stress, that could be infection, that could be vaccination.
All these things. But the bottom line is the proof of the hypothesis is that in so many people, the cancer that's come back is the same one. And in my own patients, I've had up to 18 to 20 years ago. It's not different, it's not new, it's the same one. Yet they've been disease-free for 18, 20 years. Yeah. Something happens to perturbate their immune response, and they got the same disease comes back. The only conclusion is that immune system was controlling that cancer perfectly.
Absolutely, because otherwise they could just get another cancer if it was just. Yeah. So giving the low dose naltrexone, does that allow for halving of the chemotherapeutic dose in several cancers or specific ones?
Yes, it does, and we have published this.
It's pretty well across the board then.
Yeah, across the board, and with different chemos in different models. We did all these in standard mouse models, so what everybody uses, and we could show we got the same effects with the same standard chemotherapy at half the dose if we primed with low dose naltrexone. And I give that to lots of my patients, and I then say, look, I know you really didn't want the chemo, but this can control your cancer, but it will work at half the dose. You won't get the toxicity. And then I will talk to the oncologist who's been programmed. He's got to give it a high dose. I said, no, please don't. And I send the paper, the review. We did a big review on low-dose naltrexone that's management of cancer, showing how it works on all these different pathways. Yeah. I mean, the thing that really attracted my attention is that we were able and the first to show that it switches off IL-6 production, interleukin-6. And when that was discovered,
which is a pro-inflammatory cytokine.
Pro-inflammatory, but it was called by the people who discovered it cancer growth factor. So to have an agent that switches off cancer growth factor right from the day one that you add in with your chemo and your immune therapy is fantastic.
Yeah.
And to show how effective it is, there's more than one company produces antibodies to IL-6 that you can use as part of the treatment, usually when it's far too late.
Yeah.
So actually having something that just switches off the fuel supply.
Yeah.
But at the same time, we showed it enhances the sensitivity of cancer cells to the chemotherapy because it reverses the BCL2 Bax pathway. Now, cancer cells hyperexpress BCL2, which is like a shield to cell-killing apoptotic induction. And after LDN, that reverses.
So it keeps the cancer cell alive.
It keeps the cancer cell alive, but it basically removes the shield. So this is another agent which is it was licensed for heroin and morphine addiction.
Yeah, the naltrexone.
In high doses in 1986, it was approved.
So the low dose naltrexone is a drug that you have repurposed.
I'm not the only person. I mean, it was repurposed by Bihari and things. And like most things that I've come to know of, I don't learn anything from my peers or the conferences, nor the literature which they spew out the whole time. I learn it from patients who've done incredibly well, and I'm terribly nosy. And we followed it up. That's how we did all this research.
Absolutely.
And my God, there's a lot of things out there which we have looked at and can't find any scientific justification, so we just put it to a side, etc. So that is how we've discovered how these things are so good.
Yeah.
The naltrexone again it's low dose, non-toxic, cheap. It has minimal side effects. The main side effect is usually if you're taking something with codeine or opiates in it, because they clash.
Yeah.
But apart from that, so that's just another example of simple, cheap, efficient things that the establishment wants to ignore.
Yeah.
Whereas I believe the NHS and the regulatory authorities, their duty should be to improve the quality of health care for the population by the cheapest, easiest means possible.
Least toxic.
Exactly, and least toxic, not by giving them injections to reduce their obesity.
And that's without even thinking about the massive financial savings.
Yeah.
So I overstated the case there slightly. I think I've got the idea now that the Mycobacterium, vaccae and OBNSI can greatly enhance the effectiveness of other treatments. But let's just suppose we were to give this preparation to, let's make something up, everyone at the age of 55, say. What's your thinking about how that would improve health over the next couple of decades?
Well, I would be amazed if it didn't reduce the cancer incidence. And
so we could be talking about a generic or multiple anti-cancer, for want of a better word, vaccine.
Yeah, and also it would protect them from a variety of infectious diseases that we suffer from. One of the things that I noted in my trials of people who've been on IM 101 in 2020 up to early 2021, none of them caught COVID. There was no COVID vaccine. None of them caught COVID.
And presumably would get less cases of sepsis. In A&E we're dealing with sepsis all the time.
Exactly. That's my point. It is something that if I was running a hospital and people came in and they needed to go to surgery, I would give them this first. If they came in for cancer and they were lined up for standard treatment, I would give this first because it would make it work better. With this simple thing of your innate immune system collapses, you elevate it back to normal, everything's going to improve. It's so simple.
So if I wanted, well, I do want, but I can't get. If I was able to get this, would I need a shot a year or a shot every couple of years? What's your...
I think as a prophylactic, probably a shot followed by 6 months, then a year, and then probably annually at the most. When we've used it to treat melanoma, we've tended to use the system developed by Stanford and Rook, where you give it a small injection, you repeat it at 2 weeks, then 4 weeks, and then a month, and then 2 months, but then 3, but then 6 months, and then because obviously you built it up so it needs boosting much less regularly. Now what I've learned is the people who respond to it very, very well, and we did all the cytokine testing, if you've got a really good reaction at the site of injection at 1 month, you don't need another one.
Right, so you have an injection and it goes red and painful.
Well, it's not painful, just slightly tender if you bang it.
You get an inflammatory reaction, and that means your immunity is up to scratch.
And so when it decays and the inflammation goes down, that's the time you need another one. And it correlated with cytokine. We measure all these expensive cytokine. It correlated exactly with reactions. So you don't need to do that. So that's millions saved and doing unnecessary tests.
And a tiny price, a tiny personal price, and a tiny financial price to prevent potentially millions of cases of cancer.
And I've had a patient who had not one but 2 stage 4 cancers. They kept them going for 2-3 years with a really bad melanoma, but was completely controllable, but then developed another cancer which was associated with a genetic mutation that almost certainly ran in the family, because this second cancer had occurred at the age of 50 in quite a few people in the family. And we gave this IMM, and we noted that the reaction was very good, but it faded quickly. So we'd have to give it more frequently. And that suggested that the cancer was sort of fighting, turning over, and we could measure that from tumour markers, etc. Whereas people who haven't got that underlying resistance, they've still got a good response. 6 months later, you probably give it to them yearly. Whereas this person, because the big fight with the cancer, we were giving it every 2 to 3 months. But again, this has lasted years, not
people that would have been dead years ago.
Exactly.
But hopefully people like you and me, probably fairly average in cancer risk, every year might be enough.
I agree. I would think. I personally think that it for people who are otherwise reasonably healthy but whose innate immune response is in decline, that if I was giving it prophylactically, I'd be looking at annual.
Right. Yeah. That sounds more than reasonable. And then, well, we're advised to get COVID jabs
because once you've got cancer, that cancer
jabs
suppress the immune system, which is why it's there.
Say that bit again, sorry.
The cancer has, you've got cancer, it's diagnosed, you got the biopsy, it has suppressed the immune system, which is why it's there. It's fought the suppression. And so boosting that is absolute de rigueur before you can start to attack and get rid of the cancer again. Because if you do it while the immune system's suppressed, you'll reduce it, and as soon as you stop, up it comes again, which is what we know many of these big solid tumours do. The bad breast, the lung, the colorectal, the ovary, bad prostate, all of these can fall into this. Whereas you can boost that innate immune response, then the whole landscape changes for how well you may do in future. And what's happened to a lot of my patients, many of whom were told years ago they only had 18 months to live, is that years and years later they're still here, and we've given them this, and they've run out of the standard options, but they've lived long enough that something else has been developed.
Absolutely.
And this is a really exciting thing about cancer. I've got several patients who lived long enough to be able to take advantage of a new discovery. They respond to that.
So are we open to approaches by investors and entrepreneurs to keep this manufacturing process going?
Yes, I really do hope so, because as opposed to just investing in a company that's got a certain burn rate and a certain value, when a company goes into administration, everybody's lost everything. It's a disaster. All the people invested, shareholders, there's nothing there.
And the expertise and the equipment is all set up just right to manufacture this at the moment.
So people come in and they scavenge. They're like vultures. They go, it owns this equipment. I've been after that. I'll get it for a tenth of the price of buying it brand new. That's what they do. But what I'd like to advertise is that here you can go to the administrators and get the whole caboose. They want to do the whole thing as a...
So someone could buy the job lot.
Yeah, you buy the job lot, because you'd get it for a fraction of the price as what you'd have to put in to continue to run it. But you're getting all that last 2-3 years of getting the FDA approvals.
And the trials could carry on.
The trials just take so long with the ethics and getting. All trials have multi-centre. They've all got to do their own ethics.
So the hard bit's done already, really, isn't it?
The hard bit's done. All you have to do is go in, do it, and even the trial has been mainly paid by a company that provides the main drug, which we're trying to show the IMM will actually make the outcome much better if you combine it. So that is why, I mean, I was absolutely devastated when it gone down, because there's no good logic for it. But this is
just a major retrograde step in oncology.
Yeah, this is pure financial. I mean, usually when companies go down, the product has just gone into man, and it's got, found that it's got horrendous unexpected side effects. You remember like the antibody CD28 at Northwick Park? The volunteers in the Northwick Park.
Oh, I remember that.
Yes, yeah. And they all went, I mean, some of them died, and it was terrible.
Horrendous side effects.
Yeah, they usually go down with, horrendous problems in development.
But here we've got the exact opposite.
It's just totally the opposite. There is no clinical problem. It seems to be effective in anything. There's not been one trial that's questioned its efficacy in 20 years. Not one trial. Every trial's been positive. So why can they not just wrap it up and say, use it, we'll put it on stage 4, or in phase 4, which means that rather than just write it out, well, all oncology drugs are written out in sort of like monthly cycles. But this means every month, instead of saying, are you okay, this, that and the other, you fill a form in, says everything's okay, blah, blah, and you send it back, just like it was on a clinical trial, to the company's central repository. And
so the trial could go ahead if the firm, if Imodulan is saved, but that still leaves us with the problem of the regulators that refuse to regulate it.
Well, I mean, I think if the trial went ahead and it was positive, it would then get regulation.
Right. Is it a well-constructed trial that's likely to give a fair result?
Well, I believe so. I believe it is. The only issue is, I believe they've set the bar unusually high. They want like a 50% bigger outcome than normal, which is really optimistic. The normal is 20 to 30%. That's the only thing I was taking it over, I'd ask them to reassess, because that's the real world. 50%. We got that in melanoma, but when we got it from 40 to nearly 80, it's double.
But given that there's no downside, if you said, well, if I give you this injection, John, your chemotherapy is 10% more likely to work, I'd bite your hand off.
Well, put it this way.
Because there's no reason, there's no downside.
Yeah, well, put it this way. I would want anybody that I know, and I mean, I still want them to be able to get this, and the fact I can't give it to them, it really annoys me. And there was a stage there when I could give it, if a trial was running, I could give it named patient basis. So that's
like compassionately.
Yeah, compassionate. That's how happy they were that there was no side effects. And then they came in and said, no, it's for trial patients only. And I don't know why that happened, but it was.
Well, there's precedence for that. The World Health Organization said a particular drug should only be used in the context of clinical trials, even though doctors around the world found it efficacious for treating COVID-19.
Yeah. Well, don't get me on that, because I would disband the WHO if I had.
As would I. As hopefully the new administration in the United States will look to doing.
Yeah. Well, they're certainly going to not fund it.
Yeah.
I think they made that very clear.
That is very encouraging in my view. Professor, as always, fascinating, but drives you mad.
It does. But I just hope there's somebody who listening who might know somebody who's an entrepreneur or a company looking for something like this which could greatly enhance something else they've got. And it's a bargain basement.
Absolutely.
In which all the risk has been taken. It's been totally de-risked. I mean, there are no side effects, activity in everything. All that manufacturing's been sorted out, which is always an issue when you're dealing with mycobacteria side of things. All that's sorted out. FDA approvals, trial approvals, all sorted. It is a bargain basement. I would say it's the best thing since vitamin D.
And at the end of your life, you can look back and say, you know what? I saved a massive amount of human pain, suffering, and death.
Yeah. Well, so yeah. This to me is just be so important for somebody to come in and do this.
Yep.
Because it's just a tragedy that they ran out of money, but they ran out of money because of the system.
The bureaucratic regulatory system is stacked against anyone who's not got massive big pharma funding behind them.
That's right. And I'm afraid that the big pharma are so powerful, they set their own rules and they bend the rules that exist or just rip them up. Or in the case of the COVID vaccines, they just basically lied about what had not been done, that we find in retrospect.
And a cynic might say that they're sitting chuckling about the fact that this is going down the Swanee.
Yes.
Yep.
But the other thing, we do have, and it is admitted. I mean, we were told you couldn't say. It's been all over the Daily Mail and the Telegraph of the people who had serious side effects from the AstraZeneca and the need for compensation. It's been addressed in the mainstream media. So let us not...
It's starting to trickle in, yeah.
Let us not mess around. I mean, there were serious side effects which were ignored, and doctors were even struck off for trying to do something about it.
A couple of newspapers. I don't think I've seen it on mainstream national television yet, but
well, it certainly was in Australia, because I was the guy who did it. I did it on the Sky News Australia. That was as big as mainstream you're ever going to get, and they allowed me to do that. They were told that they couldn't, but the people who basically wanted me to do it said, they were told by the government they weren't allowed to do it, but the people behind it basically they knew people personally who had so much damage they could no longer live with it. And we'd had Zuckerberg too say they paid us to censor it, and that people, you can't censor things forever. I mean, that's...
Oh, I don't know. I'm not sure about that.
Well...
I'm not sure about that. I think maybe some things you can, unfortunately. Ideas can be buried.
Well,
but that's what we fight against. We're fighting for truth and objectivity.
That's what we're fighting against. But the whole point of bringing that up was that the IMM may be the ideal solution for COVID vaccine damage. And
interesting.
And I have a justification for this, because there was a randomized trial published in patients with long COVID with BCG in a placebo. Yeah. You see, I can't remember. I cannot give you the.
No, I can't remember the details, but yes, it makes sense.
It was very good. Now I know that IMM would have been far more effective, because BCG is live attenuated, and if you give it more than twice, you get this Th2 inflammatory response, and you lose the benefit. But just giving it the once, you get that. But with the heat-killed Mycobacterium,
that's the difference.
You can keep giving it without ever inducing the inflammatory response. And that it is, if you were trying to work out what you'd need for all these things, it would be the perfect agent. You could spend hundreds of millions developing and decades to do. We've already got it. It's here. That's my message. And it would be fantastic for all this COVID damage thing too.
So the immunological perturbation, disruption caused by the vaccine, caused by long COVID potentially.
This would correct. Because it is an inflammatory Th2 response.
Yep, makes perfect sense. Professor, as always, thank you very much for coming on. And
thank you very much. And once again, I apologise for my
not at all.
But
trauma is allowed but not encouraged.
Pardon?
Trauma is allowed but not encouraged.
Trauma is allowed, not encouraged. Anyhow,
it's inevitable, but we don't encourage it.
After I'd collided with this thing, I went out and I said, "Who put that up? It wasn't there yesterday." And I got
it's public safety, isn't it?
The director of the clinic, and I said, "You see that there? I went into that. Look, my head's been bleeding from this. I couldn't see it because the setting sun is right in the eyes, and you can't see anything." I said, "Do you not think that sign should have been at least 1 or 2 foot higher, so nobody could bash into it.
It's almost as if there's a lack of common sense in this country, isn't it?
There is a total. I could be here for half an hour telling you the incompetence of everything. Absolutely, every interaction I've done with the government departments or utility services or just anything, it is beyond belief that total incompetence, and the incompetence goes with a carelessness of not really engaging. People don't seem to have a proper conscience to do. They just do things, and the outcome they don't really care about. Well, in the old days, we were very proud. I was very proud of my outcome as a doctor. I expected somebody to come in as a plumber or electrician and be very proud that they'd get everything right and think they were good. Now, I had an episode of a plumber who couldn't differentiate between a hot pipe and a cold pipe, and stuffed us up by joining the two up. We have to get another plumber in. It just goes on. It's like, that old song that they've done, is it Swan?
Yeah.
It's on the Monday morning.
Yeah.
It's just like that.
Yeah. And the analogies with medicine could be extrapolated from that.
Yes, indeed.
quite readily. Yeah. But for now, Professor, thank you very much indeed.
Thank you very much indeed. Thank you.
Thank you.
Bye.
Bye.